exhibit hall. One of the wonderful things about this conference is that there are so many ways to treat our dry eye patients and so much technology and innovation to treat our patients. And it's great to be able to learn more about these companies and to talk more and get a deeper understanding of what these companies have to offer. So I would like to bring on Dr. Cynthia Matossian to talk to us a little bit more about IMED and the technology available within this company. Hello, welcome.
Thank you so much, Jackie, for that wonderful introduction. And I'm delighted to be here with all of you, virtually, of course, to talk to you about IMED, who IMED is, and what they have to offer.
Yeah, wonderful. Let's dive right into what is IMED. Tell us about it.
Well, IMED actually has been around for quite some years, like 30 plus years, although it's a new kid on the block in the United States. It is a company that's based out of Montreal, Canada. And if you were a French Canadian, you'd say Montréal. That's the correct French way of pronouncing it. Daniel Hoffman is the current president, and they've been around in Europe, Australia, France, and Canada for about 30 years. Their whole approach is that they are a no-nonsense, very lean and mean kind of company. They're small and nimble, and they work with each eye care provider to make their product or products actually available to them to not only diagnose, but treat their patients with dry eye disease in the office, as well as send the patient home with an at-home remedy kit.
So tell us a little more, Cynthia, about who are our patients that have dry eye disease?
You know, I'm so glad you asked that question, Jackie, because of course, when we look at this R&D pipeline, there's a reason why it's so robust. It's because IMED has an entire kind of outline of how to identify and diagnose, treat, and manage these patients. And these patients are all of them you see here, or one person that's actually on purpose missing, and we did that on purpose, is the postmenopausal woman. Because of course that used to be what we used to think about, who quote unquote had dry eye. But now the face of dry eye is truly changing. It's younger folks because they've grown up with digital devices from when they were toddlers, to contact lens wearers, to men who are getting older because they too are using their iPads and watching TV and using their computers all day.
Yeah, absolutely. I mean, I agree with you. We really used to think of the postmenopausal woman, and that's not at all the case anymore. And we're seeing this in the pediatric population. So tell us about some of the tests that we use to diagnose dry eye.
One of the, I guess, unmet needs in dry eye is, up until now, the lack of easily to diagnose dry eye disease. Sure, we've had on my biographers our MMP9 tests and our tear osmolarity tests, but each one was a separate unit. What's unique about IMED is these tests, and of course we don't have time to delve into each one of them, but there are 8 in the blue kind of boxes are readily available. It's non-invasive tear breakup time, ocular surface inflammatory evaluation, Demodex evaluation, meibography, blink pattern recognition, eye redness, and eye fitness test, as well as the tear meniscus, can be done with a small unit desktop like the one pictured here on the slide by a technician in about 8 to 10 with fluorescein is about to be ready. That's why that box is grayed out.
And so, Cynthia, you cut out there for just a moment. You said those tests that are available here can be done in about 8 to 10, and then we lost you. 10 minutes. Okay, got it.
8 to 10 minutes by a technician, and it's by a desktop unit that is compact. You don't have to move the patient from one work area to another work area. So it actually is very streamlined and takes about 8 to 10 minutes. And of course, you may not want to add this on impromptu during a visit. You can if you have the time. Most of the practices schedule the patient back for a dry eye workup where they do these diagnostic tests.
That's a good point. I was going to ask you, how do you incorporate that? Who's doing this test? The technician, presumably, I think you said, and how do you incorporate this into your flow? So this is really a schedule back thing that you incorporate into your dry eye evaluations when you see them back?
It depends on how the practice runs, actually, Jackie. I'm so glad you also asked that question. If you have the time, you can do it impromptu, but most of the time, there was no additional 10 minutes in that patient slot. So if you think the patient has dry eye disease, or through maybe vital dye and slit lamp examination, you notate that, then you can schedule the patient back for a dry eye comprehensive evaluation. It's cash pay. And this way, you're not running behind, and the patient understands that they are getting a comprehensive, deep, broad dry eye workup with this tear check from IMED Analyzer tool.
So that's a good point. I think that's something I really stumbled a lot with when I first started really diving into treating dry eye patients, is I would talk and talk and talk, and then let's do this and let's do that. And then I'm running behind in my clinic because it's so easy. There's a lot to talk about with dry eye. And so this is a good point, is to really, kind of call it. Like, you can only address so many things during an eye exam. It's best to have them back, and then you can really, properly assess the patient and do a more thorough workup with, for example, the tear check.
Exactly. And also, the patient has time to start absorbing what you're saying, because, of course, they only retain about 5 to 8%, maybe 9% of everything we tell them. It's overwhelming for the patient. By bringing them back, you are reinforcing maybe what you said and then expanding on it.
Yeah, good point. What parts of the dry eye, the diagnostic parts of that, what parts are important?
What's unique about Tear Check's report is that it quantifies each one of these 8 tests, and it's the only unit that I personally know of where it can tell you the exact percentage, for example, of meibomian gland dropout, and then accordingly it puts you into these color-coded columns. You can print this right there, then and there, and hand the printed copy to the patient. So they're going home with kind of a report card of their dry eye, and it's integrated into your EMR system as well to become a permanent part of that patient's medical records. Especially for that asymptomatic patient, Jackie, this is kind of proof what many of them need to kind of become believers that indeed there is something wrong with their tear film. Indeed, they do have dry eye disease, so that they become more compliant with whatever it is that we as eye care providers recommend for that.
I've certainly found that pictures are so much better when you are really trying to get a patient to understand or even buy in to what the treatment is that you're recommending. One thing I noticed on the tear check is that there's an eye redness scale, which I think, right now when I've got a red eye, I'm grading it pretty grossly as a 1, 2, 3, 4 kind of conj stain or conj redness. And there are ways, like this technology is a much more accurate way to sort of really monitor that and the progress that you're making with the patient in many variables. Eye redness is one of them, but meibography can be another. And are you able to compare these meibography, levels from previous treatments then as well?
You really are. And that's what's unique about this quantified report, is that First, it will help the eye doctor make the diagnosis. It will help the patient get a quantitative report. Then we as providers can initiate treatment and then monitor the effectiveness of the treatment over time by repeating the test. So let's say we initiate treatment XYZ, we give it an appropriate number of months for it to work, and then we bring the patient back and then we repeat this test. And those numbers should start to go from the red column to the orange to the yellow over time. Another thing that this is great for is to assess patient compliance. We know compliance among patients for chronic diseases is notoriously bad. They're not going to be taking their oral omega supplements or doing whatever it is we ask them to do religiously. So this can also monitor how compliant the patient is and demonstrate to them that you were doing great, but did something happen? Did you stop doing your at-home remedies?
I find that a lot with patients, even when I'm talking about doing an at-home therapy. Some patients are really great about being honest and saying, I'm not going to do these warm compresses. I know you're telling me to do them, but I'm not going to do them. So those patients are great because I say, okay, fine, let's do X, Y, or Z. But there are certainly patients who aren't that honest or won't verbalize that to you. But having the report, you can certainly monitor how compliant are we, what's the improvement like, and then I feel like you might take an exam to maybe realize that with the patient, but then they might come out with that level of honesty with how compliant they are.
Exactly. And sometimes, you ask your patients that question, I do too. I look at them in the eye. I say, please be honest. Accordingly, we can craft the type of treatment that's right for you. And if they say, Dr. Matossian, I know I'm not going to use those warm compresses or do the lid scrubs, then I actually may go to a different treatment algorithm, knowing that they're not going to be compliant at home. For example, that's when I might recommend an IPL treatment, and IMED's IPL is called IR. There's an extra R there, IRPL, and the R stands for regulated. They've been around again for since 2015, and they were actually the first company to get an indication worldwide for using IPL for meibomian gland disease. And of course, now they've recently entered the US market. Because of their proprietary regulated intense pulse light treatment, you don't have to do 2 passes, you just do 1. And the number of applications is also significantly less than other available technologies.
Super interesting. I mean, this brings up a good point on treatment. There are so many different treatment options for a patient. How do you decide what treatment option is best for that patient?
For example, a non-compliant patient, and when they tell you, I am not going to do these things on a daily basis, that person may be a perfect candidate to undergo an IRPL. Obviously, an IRPL can only be done on patients with a Fitzpatrick skin scale of 1 through 4. Unfortunately, it's not approved for anybody with a darker skin tone. So for those patients, an alternative type of treatment has to be recommended. Also, this unit is small. It has a portable travel case that has wheels and a handle. So for doctors who have multiple offices or maybe satellite offices, this unit is desktop, lightweight, and very readily transportable.
Yeah, that's certainly one thing that I noticed about the size of that device is, I have an IPL now. It's certainly much larger than this IRPL that I'm looking at here. So that is certainly valuable, especially for multiple locations. You can invest, into this technology, but not feel like you have to do it in multiple different places if you need that portability. So that's wonderful.
And also, Jackie, if the patient has telangiectatic vessels along the eyelid margin, where you can see the prominent dilated vessels contributing to that eyelid hyperemia, These folks would be fabulous candidates for an IRPL. Patients who have rosacea blepharitis, do extremely well with this proven technology.
Yeah, I've totally found that in my practice as well. Do you feel like the IRPL can replace some other thermal therapies that are on the market?
Um, Dry eye disease, MGD, is such a multifactorial disease that we all have learned along the way and are continuing to learn that there is no one best approach. To me, it's like making a perfect soup. You have to add a little bit of this, add a little bit of that, keep tasting it to get it just right. It's the same with dry eye disease. For example, I pair my IRPL with thermal pulsation therapy, with topical pharmacological prescription medications, with at-home remedies. So it is many different treatment modalities to kind of bring together to deliver the patient the type of treatment and the level of treatment that their disease warrants. Obviously, it has to be tailored to each person because each person's level of disease or combo of signs and symptoms is unique to that person.
Yeah, I discuss this with my patients too, and I think it's almost about setting expectations for that patient, understanding it is not one drop. I mean, you'll hear patients say, "Can I just take an eye drop that will help this?" And really, it's not. And I think it's important to set the expectations, but certainly things like tear check can really give more information in terms of a myography image, which I feel like speaks volumes to patients when you say, "Listen, this is the root cause. We have inflammation in this eyelid. Let's take these following steps to really kind of hit it from all sides," if you will.
Exactly. And so, of course, using the IRPL, you're hitting the inflammatory component. You're hitting those abnormally dilated blood vessels because you're causing them to shrink back and stop leaking those pro-inflammatory mediators. But concomitantly, you might need lid scrubs. You might need oral omega supplements, or a pharmacological agent, or even a steroid for those occasional flare-ups.
Yeah, absolutely. I think IRPL has been transformative, really, to treating our dry eye patients. There's a lot of IPLs and out on the market. I'm wondering, why IMED? Why is that your choice?
The reason why it's really our choice now in some ways, for especially practices who are starting with the treatment of dry eye disease or wanting to establish a dry eye center of excellence, is because it's one company that has all three arms under its umbrella. It has the in-office diagnostics, small and portable and affordable. It has the in-office IRPL treatment, and it has this group of options for patients to take home and use them for their at-home remedies. So under IMED, you don't have to go to the different companies to utilize product A from company A, product B from company B. You can do it all under IMED. For example, their at-home products include different kits like the ones demonstrated here. The main difference is that eyelid and lash jar that you can see, one has a yellow, one has a green stripe. The green one has the added tea tree oil for patients in whom you're kind of suspecting Demodex. So that's the difference between the green and the yellow stripe. Otherwise, the kit contains the same products. They also have an artificial tear ointment that has hyaluronic acid in it and a hypochlorous acid spray. So, depending on what's going on with the surface of your patient, you can do the diagnostics, the in-office treatment, and the at-home remedies.
It's really useful. I mean, the sort of a three-prong approach really is available under one umbrella, which is nice. You don't have to sort of navigate through different companies to find what you need. So it's wonderful. Cynthia,
And that's what makes it unique.
Yeah, absolutely. Any closing thoughts here before we recap?
That IMED, I have the information of Brent Jones right here on the slide and Michelle Schnabel, that each of them would be more than happy to speak with anybody interested. Or, of course, you can Google IMED and contact them, but they are here to help each of you who is interested in their technology.
Great. Cynthia, thank you so much. You are such a strong presence in the dry eye community. It was a real pleasure speaking with you today. Thank you for being here.
Thank you for the invitation.